Doc Talk with Dr. Paul Conley is a production of TTV, which is solely responsible for the content.
Hello, welcome to Doc Talk. I'm Dr. Paul Conley, and tonight we're going to be talking about diabetes. And so we have Dr. Charles Burdette on with us tonight. And Dr. Burdette has been on the show before, and we've talked about cardiovascular health, we've talked about heart awareness. And one of the things that we talked about with heart awareness, we've talked about how diabetes is a causation of heart disease. So tonight what I'd like to do is delve into diabetes itself, because when we think about diabetes in this country, over 41 million Americans have diabetes, with about 11 million Americans that don't even know they have it. They remain undiagnosed.
Absolutely.
And then I'm going to have you talk a little bit about this term that we talk about called pre-diabetes. And pre-diabetes is a condition where your sugars are running a little high, but you're not quite in that diabetic range. 115 million Americans have this condition. So, Dr. Burdette, thanks again for coming on to the show.
Thank you, Doc. Thank you for having me.
So when we think about diabetes, we're going to talk a little bit tonight about the differences between type 1 and type 2, and I know we'll talk mainly about type 2 because that's what we're going to mainly see in this country. And maybe you can just tell us what is the difference between type 1 so people out there can understand what that means. I know we always think about the word juvenile diabetics and adolescent diabetics, but it can actually affect adults as well.
Absolutely.
And then I want you to talk what the most of the show is going to be about is the type 2 diabetics, okay, which is what we're talking about. Most of the Americans, these 41 million Americans, most of those are going to be type 2.
Absolutely. Well, type 1 diabetes, actually I have a personal connection with type 1. My youngest son is type 1 diabetic. He was diagnosed at 8 years old. That's, as you said, the juvenile diabetes. The ones where people their pancreas no longer produces insulin at all. Usually that's due to an autoimmune disorder. The pancreas is destroyed, what's called the islet cells or the beta cells that we won't talk into a great deal, but that's things that you'll hear. That's where the insulin comes from in the pancreas. Those are destroyed, and then the patients require insulin to maintain their glycemic control. Type 2 diabetes comes from a different form, and that is where we develop two things. One is insulin resistance. Insulin works on several tissues in the body, primarily the skeletal muscle, the adipose tissue or the fat tissue, the liver, and also heart muscle. Those are the primary ones. There's some other ones, but those are the main ones that are affected. Then there's also the overproduction of the insulin that happens that then actually burns out those cells that we were referring to. Because of the body becoming resistant to the insulin, the sugar goes up. You then need to produce more insulin. That then basically just burns out the pancreas, and then you end up with the hyperglycemia, which is the hallmark of diabetes.
So when we think about type 1, it is again that individual may be very thin, may be very active, and what you see many times is this kid or juvenile doesn't even know it, they're not even aware, and then they can present to the emergency room with like a diabetic ketoacidosis. And these individuals have sugars in the hundreds, 6, 7, 800, because they're just not able to produce insulin whatsoever. But
correct.
But what we're thinking about in this country when we talk about type 2 diabetes, that's basically 95% of what we're dealing with, and that's again that insulin resistance. So that individual, when you do blood work, their insulin level is going to be high, but the body's just not able to quite utilize the insulin properly because there's a dysfunction with these receptors. And so when we think about what would cause, let's think about some of the causation. What causes these folks that have all this extra insulin produced, but the body's just not really utilizing it?
Right. Well, that is an excellent question, and that's a good point for our folks out watching, is what creates that? Unfortunately, most of the time it's obesity. Obesity is the #1 cause of type 2 diabetes. It also takes time to develop type 2 diabetes because the insulin produces all of that insulin. The pancreas produces all of that insulin. Then the cells can't work with it. They can't do anything with it. Then that increases the sugar level in the blood. and it takes time for that. That's the big cause is, it was obesity. People are genetically disposed, so it does run in families. You will see that mom, dad, grandma, grandpa had it, Uncle Fred, etc. And then unfortunately you can develop there as well. So anyone who has anyone with type 2 diabetes in the family should be going to their primary cares and getting those levels checked if they have any symptoms. And perhaps we should talk about the symptoms at this point about that.
Yeah, so I guess that's a good question. So when you talk about how would someone know or even have a clue that they have diabetes? And maybe you can even tell us when we talk about pre-diabetes and diabetes, maybe you can also tell the audience like what is considered a normal fasting glucose, because I think some of my patients don't really quite know the numbers. I know in our prior show we talked about knowing the numbers and how you know you can't manage what you don't measure.
Absolutely.
And I think that sometimes people don't quite understand what a normal blood glucose actually is.
Very good. That's an excellent point, Dr. Conley. When we look at knowing the numbers, blood glucose is the number one thing that people think about. Those numbers have changed over the years as we've looked at, as diabetes has gone through, they've done the research. The numbers really you're looking for when you're looking at a fasting blood glucose, when they do your labs at the lab, is 100. Anything below 100 is considered normal. 100 to 150 is where we start to worry about that pre-diabetes. Anything at a fasting glucose, and that's the important thing when they do those testing, is fasting. At least 4 to 6 hours of fasting. You do that test, if it's above 150, you definitely should have your A1C checked. Knowing the numbers, that's another thing on the A1C. A1Cs, when they look at that, it's the numbers, everyone thinks about those numbers, they hear them all the time, they see them on television. Below 5.6 and below 5.6 is normal. That's where we consider you're having a normal glycemic control, okay, that how your body is processing the sugar. 5.7 to 6.4 is what you were referencing earlier, pre-diabetes. That's people who aren't at that point yet. They're not developing the symptoms, but their sugars are starting to rise. They're starting to get to that point. But an A1C above 6.4, that's diabetes. And once you kind of reach that number, you're diabetic. And basically you're diabetic from now on. But there's ways that we can control you with medicines, exercise, diet, those sorts of things that I think we're going to talk about later.
So I know that when people think about what is a hemoglobin A1C, because I think what sometimes will happen is someone will come in with a normal or a reading that's fasting that's 100. But then what happens when you have insulin resistance, they go eat, let's say, a meal. They get your blood work, and then they go out to get breakfast, and they eat a bunch of pancakes, they eat syrup. And then that postprandial glucose goes up, and then that's where that A1C, because that gives us an average. It's basically measuring the red cell, and that red cell, as it's circulating through the circulation, it's sucking up some sugar, and that gives us that percent. So that number, that 6.5 is a percentage. So what percentage of that red cell is sugar? And the higher the percentage that red cell is sugar, that reflects the fact that your glucose, which many times can go up and down depending on what you eat. And so that's why it's so important that people understand that, because sometimes if people only look at their fasting glucose, they may think, hey, I'm doing okay, and they get an A1C, and you're just like, hey, it's 7.5, and you're like, oh, how is that? Well, because when you eat a meal, again, you don't have the receptors, the insulin receptors, that are actually, they're dysfunctional.
Yeah, I mean, that's a very good point. Many times, unfortunately, not quite daily, but at least 3 or 4 times a week, I will have a patient who will say exactly that. I'm checking my glucoses at home because my wife has a machine, my daughter has a machine, my mom or dad did, and they're fine, they're 120, they're 140, but then I do an A1C and it is elevated because that's that 3-month average. We're able to see, as you said, after people have those meals, can their body maintain the control on the glucose, keep it below those numbers we've been talking. And unfortunately, that's not always the case. And some of the symptoms can be very subtle, and they don't really recognize them until they find it on blood work.
So we think about some symptoms before we go to break. I always think about, polyuria, polydipsia, and that's always, that's where you drink and then you pee and you drink and then you pee. So I know that's one of the symptoms, but maybe you can kind of tell us what maybe some of these early symptoms may be, because I think they're going to be real subtle.
Yeah, exactly. As you were saying, the people who feel like they need to drink all the time, or they're peeing much more often, especially when they're seeing the urine happening all the time, and which is an interesting story. We'll get off into a little side on the bar. The way a lot of diabetes was found was because of how the ants would react to urine. They would go into urine bowls and things like that, and they were looking for that sugar. So back, the 1800s, diabetes has been around since ancient times. So this is not a new issue, but that's what they would look for. But, back to the symptoms, they would urinate all the time, very clear urine. A lot of times people feel very tired, fatigued, particularly after they eat. A couple hours after they eat, they just want to sleep. They just can't really keep themselves awake. They'll gain weight. Their weights will go up a lot. They tend to be hungry all the time, and they'll have those cravings for the sugar. And anyone who is diabetic, they're probably sitting there nodding their head watching this episode. They'll get very hungry and they'll get cravings. They want that sugar, that sugary food of some sort. So those are some of the early signs and symptoms.
What about vision? I know sometimes people will tell me that that was one of the things that clued them in, that they would eat a large meal and then their vision. Is that something that people may suffer from, some vision changes as the sugar fluctuates?
Absolutely. That was one that unfortunately I forgot to mention, was the vision. Due to the sugar's activity within the eyeball itself, or within the globe, within the eye globe, sugar draws water to itself, and it will cause the eyeball to swell and shrink. And yes, they'll have blurry vision that comes and goes. They're good for a while, and then they'll have a meal, as you said, a very large carb meal or sugary meal. And then within a few hours, or maybe the next day, their vision's not quite right. And then it'll get better over a few days. And so, yeah, that is.
Because I've had patients tell me, hey, I see you got your glasses in your hand, I just got some new glasses, and there's something wrong with these things because they come and they go, and what they don't realize is because their sugar is going from normal to 300 to normal to 300, and they get the vision changes. And one of the things that we can see, too, that, medical school, we used to talk about, foot and glove stocking distribution, even neuropathies, but that's usually when someone's had more of a long-term sequela, but they'll come in with neuropathy, lack of sensation of their feet and toes. They can't even feel their feet, and those are all also signs of diabetes.
Those are signs of diabetes. Luckily, but also unfortunately, that's also a sign usually that they've had diabetes for 5 years or more. Usually it's about 10. 8 to 10 years is when neuropathy starts to show. So if you have that, you may have been diabetic longer than you thought.
One thing too is, before we go to break, is one thing that I know that you would want to also test is even the sugar and everything in the urine, but there's also spillage of protein and things like that that we would look at. And we're going to talk a little bit, when we come back from the break, we're going to talk about what all does diabetes affect. I mean, talking about vision changes, and we're talking about sleepiness and polyuria, polydipsia, but we also know it affects your heart, it affects your eyes, kidneys. And then also, when we come back from commercial break, there's all kinds of new medications out there, Dr. Burdette. We're going to talk about some of where we started in the past, starting from insulin to some of these orals, and everybody that watches TV of any sort is seeing these GLP-1 agonists, the Ozempics, the Mounjaros. So we're getting ready to take a commercial break, and when we come back, I'm going to be here with Dr. Burdette. He's going to talk to us about these GLP-1 agonists and other types of treatment for diabetes. So I'm Dr. Paul Conley, Doc Talk, commercial break, and then we're going to be right back.
You're watching Doc Talk with Dr. Paul Conley on WZTS 16 Cozy TV. Stay with us. We'll be right back after these messages.
Vandalia Health is proud to be a West Virginia-owned healthcare system, bringing together the hospitals and providers of CAMC, Mon, and Davis. We are dedicated to enhancing the health of our communities through clinical excellence. Our compassion and commitment remain the same, with people you know and trust to care for you and your families. With more specialists, hospitals, and outpatient locations, we are delivering expertise and state-of-the-art care. Vandalia Health, expert care close to home.
Welcome back. Doc Talk with Dr. Paul Conley continues on WZTS 16 Cozy TV.
Welcome back to Doc Talk. I'm Dr. Paul Conley, and we're talking about diabetes. My guest tonight is Dr. Charles Burdette, family physician here in Fayetteville, West Virginia. And Dr. Burdette has been talking to us about diabetes. He's been talking about the epidemiology, how many million Americans there are, 41 million that is, actually 41. With diabetes, but the 115 million Americans that are in that pre-diabetic range. So we're going to talk about, here in the second half of the show, we're going to talk about some of the medical conditions that are associated with diabetes. And with these medical conditions, it is the most expensive chronic disease state in the country. 640 billion, with the B, $640 billion spent each year due to diabetes. So, Dr. Burdette, that's a huge number, $640 billion in healthcare expenditures due to this one condition, and that's diabetes.
Yes, sir.
We know that is basically, if you're a diabetic alone, your healthcare expenditures are more than double an individual that doesn't have diabetes.
Absolutely.
So maybe with that, we think about diabetes, but what all is some of the comorbidities that we talk about? It's not just high glucose, but it causes so much damage. We talked about cardiovascular disease. Again, that's the #1 cause of death in this country is heart disease. Diabetes is the 7th leading cause of death in this country. But what all does diabetes do to one's body, and what are some of the complications that we'd like to talk about?
Absolutely. As West Virginians, we were talking about the cost. When I was preparing for the show, $2.4 billion in 2022, just here in West Virginia, was the numbers. But to answer your question there, Dr. Conley, we talked about the eye issues in the first segment. As we just kind of go from top to bottom, of course, the next thing is heart, cardiovascular. You were mentioning that. Cardiovascular damage from diabetes is probably the second worst issue. The worst issue is with the kidney disease that comes from diabetes, and that's from the kidneys trying to process that sugar. One of the protective mechanisms with the body, as you well know, is the body will push glucose through the urine, and that's why you urinate so much. That's why when those numbers go up, I used to know when my son that we mentioned about type 1 diabetic, I knew when his numbers were up because he's running back and forth to the restroom. And that's how that happens. But unfortunately, because of that high sugar and that process, it damages the kidneys. Then that leads to hypertension. Then the hypertension actually starts to cause the issues with the heart and the vascular system. Then you add in the increase of, cholesterol, as we were discussing. You start to add in, as the process of diabetes goes on, it creates the process where the adipose tissue, the fat tissue breaks down, releases a lot of cholesterol into the body. The body has to process that. Unfortunately, it then leads to plaques and blockages within the vessels. Then the sugar being elevated goes into the neuropathy that you referenced earlier in the show, goes into that stocking and glove, as we talk about, those feet and hands, primarily the feet and below the knees. The sugar stays up, it stays elevated, it goes into the tissues, it then causes damage to the nerves, which then leads to that tingling, numbness, burning that people complain about in that. And that's kind of very high level, run through some of the major complications. There's so many others that we can talk about, but those are some of the major ones.
Well, and I'm just going to throw out there with, doing a lot of gastro work, is that I don't think people are aware of what it does to your liver. So we're seeing a lot of non-alcoholic fatty liver disease.
Yes, sir.
And we do know that if you're a type 2 diabetic, 3/4 of our type 2 diabetics, 3 out of 4 have fatty liver disease. And fatty liver disease is now become the #2 cause of liver transplant in this country, because what it does is, again, all that sugar causes the liver to be inflamed, it causes fibrosis, and fibrosis can then turn into cirrhosis. I think a lot of people think, well, if I don't drink alcohol, why would I have cirrhosis of the liver? Right. You cannot drink a drop if you're type 2 diabetic and you have fatty liver disease. It can progress into fibrotic liver disease, which then can progress to cirrhosis. But you think about West Virginia, which we are here in West Virginia. We're in Fayetteville, West Virginia, actually. And when I was kind of looking at some of the numbers, as I had my doctor's appointment with you,
Yes, sir.
I was looking at some numbers in West Virginia. We're the worst. We are the worst.
Unfortunately.
So when you think about our state, 18% of West Virginians have diabetes, which nudges out Mississippi, which is 17%,
Right.
which barely nudges out Louisiana, which is 16%. But we have the highest percentage of diabetics in the country,
Yes, sir.
which is one reason why we have such high health care costs. On the flip side, Colorado and Vermont, 9.3%, 8.6%. So we are actually more than double these other states. And so, and that's a real problem. We were talking about, actually before we went on the show, how you're talking about the percent increase with adolescents, because it starts with our kids. Because if you're obese, overweight as a child, all these fat cells, they don't go away. Even when you lose weight, the fat cells, they shrink down, but they don't just disappear. And so when you start out as an adolescent obese, then it just multitude increased risk of having diabetes as an adult, correct?
Yes, sir. Yes, sir. Well, as we were talking about, we were looking at the statistics before the show, looking at the CDC statistics, and from 1999 to 2001, there was about 22% of adolescents that were pre-diabetic or diabetic. From 2020 or 2021 to 2024, it had jumped up to 32.7%. So almost 1/3 of our adolescents, 15 to 18 or 17 years old, 14 to 17, pardon me, was the numbers they were looking at, are pre-diabetic or diabetic. And that's a little worrisome with the childhood obesity that we were talking about. It gets into a lot of different discussions that are probably deeper than we want to go into on this show, but
so we got to really get those kids. We got to get them exercising. We got to get them out there losing the weight, because if you're pre-diabetic as a teen, it's really going to be tough as you become an adult to lose that weight. And then again, we're talking about $640 billion spent annually with this condition. So let's talk, as we're running out of time, about therapies. And so I think people watching the show, well, how do I attack this? How do I treat this? I know my numbers, my A1C is high, my cholesterol. So how do we treat, we were talking about blood pressure, so maybe you can talk to the audience if you're diabetic. We know there's certain blood pressure readings you want to see. You want to see certain medications for your blood pressure, cholesterol. Maybe you can talk to us about what we use to control the sugar.
Absolutely. Well, as we were discussing, we were kind of looking at many things, and just kind of give an idea of where we've come from, where we were, and where we've come to on the treatment plans and on the medications. In the 1920s, up until 1920, everything was just basically don't feed people. It was starvation diets. That's basically how we treated people with diabetes. It was really into the and after 1920s is when insulin was found. It's when they started doing the experiments with dogs, where they would remove their pancreas and see how fast diabetes would develop and things like that. Then insulin was brought from cows and horses, was given to humans, some of the very first experiments here in the U.S. and also in Europe. And then until 1950, so up until the 1950s, the only thing we had was insulin. After the 1950s is when things like the precursors to metformin were starting to be developed. The sulfonylureas were being developed. And then that was kind of the mainstays until the 1990s, when metformin became the treatment here in the U.S. Currently, the recommendations is if you're pre-diabetic, you should be started on metformin. Also, you should be looked at your hypertension, as you were mentioning that. You should be looking at being started on an ACE or an ARB, something like losartan or lisinopril, something like that, to protect those kidneys, because kidney disease is a major issue within that. Then the next step up is if your A1Cs continue to progress, as we were talking about, if you get above that 6.4, one of the newer medications, the GLP-1s, which everyone wants to talk about today, your Ozempics, your Wegovy's, your Mounjaros, I was going to say metformin again, my apologies, Mounjaro, Zepbound, those are the medications to look at. Right now we're actually starting to see orals coming out in those medication types, but those are still the weekly injections. Or you can go to what's called the SGLT2s. You know, those are your Jardiance and Farxigas. Those are being used much more now with folks who have the cardiovascular disease that we've talked about. They're actually using those because it's protective. People may not be diabetic, but they're being started on those because they are protective from a cardiac standpoint. But of course, the big things is the Ozempics and things, the GLP-1 agonists. Those activate those receptors on those cells we were talking about, to help minimize the production of sugar in the body, to help produce more insulin, to help those tissues we were talking about, like the skeletal muscle and fat tissues, be able to use the insulin more. And that's kind of from a high level of what those medicines are doing. They also help to reduce weight, which is a big thing we were talking about in producing the reduction in helps to reduce your hunger centers, reduce those cravings. It also helps people, they get full faster, they don't eat as much, so that helps on those. And then also the production, or excuse me, those effects on those other tissues, like the liver that you were mentioning, on the pancreas, etc., that helps with those. That's kind of a high level on those treatments, sir.
Well, we used to use like sulfonylureas, that's your glucotrol and glyburide and Amaryl, and we don't use those as much anymore because I think a couple of things. One is because hypoglycemia, that's where the individual sugars would drop. So when the sugar would drop, what does the individual do? Well, they eat a candy bar, they drink something sugary, and so a lot of times they had a heck of a time losing weight because the sulfonylurea was causing lows, and so to counter the lows, you would eat more. We know that insulin itself is also what we call lipogenic, and so people that are on insulin a lot of times will have a heck of a time losing weight. So, well, doctor, you told me to lose weight, but you put me on insulin, and when I put on insulin, now I'm gaining weight because of the insulin. And so I think, you know, these newer agents that we're talking about, the SGLT2 inhibitors we see, but those also help excrete glucose out of the kidneys, and so you're actually losing glucose, and you're losing grams of glucose. You're actually going to lose some weight. Also helps lower blood pressure, and these the GLP-1 agonists that are out there as well. So, and we see those actually in the liver world too, because we talk about fatty liver disease. You know, I think, you know, again, checking the urine, there's one thing that you guys check, you know, which is urine for protein. Make sure that patients are clear on that. That's where the ACE is. Anything that ends in PRIL, P-R-I-L, that's going to be an ACE. An ARB, that's the sartans, and that's an ARB, because those actually help protect the kidneys, because, again, the number one cause of dialysis in this country is diabetes.
Yeah, you make excellent points, and that's one of the things, you know, when we're looking at talking about how we evaluate and treat, you know, getting your blood work, also urine work. Every time, if you're diabetic, you go to your doctor, you should be ready to pee, because we need to look at that. We need to evaluate that proteins and make sure that we're not developing any early diabetic kidney disease, because in all of the worlds of medicine, the earlier we find things, the sooner we treat it, the less complicated, the less problems we have, the better people live.
So how often, 1 minute left, so 1 minute.
Sir.
Eye exam, foot exam, urine exam. How often, patients watching the show, how often do you check someone's urine for spillage of protein? How often should the eyes checked? How often should they see the doctor?
Absolutely. They should see their doctor every 3 months. Lab work is usually every 6 months. Eye exams should be done at least once a year. And foot and ankles are looking for neuropathy at least every 6 months, or as symptoms develop.
So again, that urine, you're going to make sure that you're getting your urine checked, getting that lipid checked, checking your cholesterol, check those eyes. The urine test will pick up some abnormalities before you even detect it on the blood work.
Absolutely.
Well, Dr. Burdette, it's almost time to wrap up. I really appreciate you coming on the show. I know we went over a lot of things here of diabetics and the diabetes in general. And moving forward, you know, thanks for coming on the show. And I hope to have you. Yeah. You're always welcome to the show. I'm Dr. Paul Conley. We've been talking about diabetes here with Dr. Burdette. Until next time, have a good night.
Vandalia Health is proud to be a West Virginia-owned healthcare system, bringing together the hospitals and providers of CAMC, Mon, and Davis. We are dedicated to enhancing the health of our communities through clinical excellence. Our compassion and commitment remain the same with people you know and trust to care for you and your families. With more specialists, hospitals, and outpatient locations, we are delivering expertise and state-of-the-art care. Vandalia Health, expert care close to home.